heard about antibody drug conjugates coming into forte in the management of lung cancer, and this was a late-breaking abstract which was presented at the ESMO meeting in Madrid this year. Now we know that TROP2 is a transmembrane protein which is overexpressed in lung cancer. When we look at adenocarcinomas, about 64% of tumors do express TROP2, and in terms of squamous carcinomas also the expression is seen in about 75% of patients. And this TROP2 can be used to formulate an antibody drug conjugate, which is the Dato-Deruxtecan or Dato-DXd. And the phase 1 studies did show that there was very promising data with a 26% overall response rate. However, what we don't know is that the question still remains after so many years, that can we do better than Docetaxel as a second-line agent following progression on first-line therapy in an advanced metastatic non-small cell lung cancer. And in terms of evaluating that, the TROPION Lung 01 study was designed to look at this novel antibody drug conjugate which was targeting TROP2 head-to-head with Docetaxel in this group of patients. When we look at the study design, this was a phase 3 open-label global study which enrolled patients irrespective of the histology or whether they had the targetable mutation or the TROP2 expression levels. The authors then evaluated and randomized these patients 1:1. Approximately 300 patients were randomized in this study, either to receive the Dato-DXd versus Docetaxel, and they were evaluated to look for potential efficacy. We see here that the trial had dual primary endpoints. One was the progression-free survival in the intent to treat population, and as well as overall survival. And when we look at the current presentation and the current paper, the primary endpoint, one of the primary endpoints, the PFS, was presented for the intention to treat population. And they see that there has been a statistically significant benefit which has been noted across all the patients. When we look at the hazard ratio of 0.75 for the entire population. However, this actually translates to 4.4 months of median PFS versus 3.7 with the Docetaxel. However, when you look at what is the subgroup evaluation here, and when we look at the a little close evaluation, we see that the divergent curves especially appear more significant with the non-squamous histology as compared to the squamous histology. And these are the group of patients who actually did better, and here you have a hazard ratio of 0.63 and a PFS for non-squamous is 0.7, and duration of response is also about 7 months. So possibly this appears to be a superior treatment for patients with non-squamous histology, those who even have or don't have an actionable mutation. The other dual primary endpoint was the overall survival, and at this interim analysis for the overall survival, there was a slight trend which was favoring the Dato-DXd 11 versus 12.4 months. However, when we look at this, we see that the non-squamous histology, the hazard ratio is 0.77. The squamous population hazard ratio is 1.32. In terms of overall safety data, now we all do have some experience in managing ADC related toxicities. Some of us have used NHER2 or TDXD, and we are regularly using PD-L1 in breast cancer. And when we look at the safety profile, we do see that Dato-DXd does have a slightly better safety profile as compared to Docetaxel. Any grade toxicity was seen only in 25% versus 41% patients. And there was a low number of patients who actually underwent any kind of dose delays or dose reductions or dose discontinuation with the ADC as compared to Docetaxel. However, there are certain unique side effects which are related to Dato-DXd. They essentially are mucositis and stomatitis, but they generally are low grade and can be managed with local treatments. We also know with the experience of TDXD that interstitial lung disease is another toxicity which is common with Deruxtecan, and some of these patients did also show drug-related interstitial lung disease. So when we look at the stomatitis and oral mucositis associated with the Dato, it leads to a lower rate of discontinuation. Dry eye is also another common ocular event. So many a times patients need to be given prophylactic moisturizing eye drops. And interstitial lung disease is also a drug-related adverse event which we need to monitor. So in conclusion, we see that Dato-DXd is the first ADC which has demonstrated a statistically significant improvement in the PFS over docetaxel in patients who have previously been treated with metastatic disease. Now this was in all comers, irrespective of whether they have been treated with immunotherapy, whether they have been treated with targeted therapy or with chemotherapy, and the patients were not selected on basis of what mutation was there, they were all comers. PFS was mainly driven by the patients with a non-squamous histology. There were fewer grade 3 or more treatment-related adverse events which were observed with the Dato-DXd arm. More than grade or equal to grade 3 interstitial lung disease was seen, and we need to monitor these patients very carefully. And the interim overall findings do favor Dato-DXd. However, the trial is currently continuing to the final analysis, and Dato-DXd does appear to be a new treatment for patients who have been treated previously for non-squamous NSCLC. And I thank you all and the organizers for having us here.